First of all, thank you very much for the invitation to present here on the value-based procurement. So a big thanks to the Belgian Association of Hospital Managers, Hospital Directors. In this introductory speech, what I'm aiming to do is to somewhat indicate how a procurement will be actually able to unlock value-based healthcare, even within a Belgian setting. That's the challenge that we're taking on here. And in order to do that, I wanted to go over the concept, but also to indicate which are the current state of play and which are the concrete tools that are available in order to get to this stage. As a disclaimer, what I'm actually presenting is a shared view which is based upon the work done in the context of MedTech Europe in partnership with the Boston Consulting Group and with the community of leading procurement organizations. A lot of the information can be found under the value-based healthcare, so VBP community of practice. Also is based upon some papers which were co-authored and also on a quite inspirational paper of how to incorporate value in investment decisions in health by Professor Atoun and colleagues, and then also of national and international value-based healthcare innovation procurement related initiatives to which a personal contribution was given to those activities. And for this work within the panel, several people are also present there as well. So if we look at the starting point, I think the starting point that we can say is that we have challenged healthcare systems, that we actually are in let's say a perfect storm, and these slides were created just before the COVID. I think we're now going from a perfect storm to, I would say, almost a tornado, which will provide also the opportunity to foster some change within the system. From one end, we have healthcare systems which are under an overall pressure as we see variations in the outcomes, a continuous increase in the cost of cares, but also a significant variation in the care delivery that we see amongst the different providers, and a consistency in inefficiencies within the system, and also the challenges with regards to the resources in order to have a good care delivery provided. At the same moment, there is also the mounting obstacles within the provider-supplier relationship. There is a focus of actually moving towards more and more a price-focused, transactional focused in the purchasing of the technologies. The innovation is clearly under pressure. So really to see how to bring in relevant innovation in those financially challenged systems is quite an obstacle, and it's clearly there are misaligned incentives, and I think that was alluded to already in the beginning. There is clearly a misalignment in incentives which actually hamper this provider-supplier cooperation in order to innovate the care delivery and to bring the innovation into the systems. So a little bit more into detail, especially on the misaligned incentives. There is also a degree still of a lack of trust that between the supplier and the providers, that a partnership can be built up to joint efforts in order to make a change, to see how the innovation in the delivery of care can be optimized. And this is something which is quite critical, but also the policies which are not conducive to, or even to, which hinder the movement to a value-based healthcare implementation, a value-based procurement. So what is now a view in this change of the system? So one of the views is the vision which is brought forward with regards to value-based healthcare. Now, it's something that actually originated within the US, where people were looking at how can we actually move from more the, let's say, the input side of what's actually the amount of money that's invested into the system, where in the US it's almost double of the investment than in other jurisdictions with even a more poor outcome. So how can actually this outcome become actually in focus, and to see how to reach this outcome in the context of then the cost which is actually given to it. So how can this be optimized? And so really looking more at the ultimate outcome and the benefits that the system is bringing, primarily towards the patients, and in that way to see how this can be implemented. So that's somewhat the overall vision. And there are multiple initiatives underway in order to structurally move the health systems in this direction. This equation and the original proposal was by Michael Porter. There is a Value Institute which is actually looking into this. There is also the World Economic Forum, which is looking at bringing value into healthcare. There is the G20 Value-Based Healthcare Hub. So it's when the Saudis were having the leadership, they actually created a value-based healthcare hub, where there the focus really has been to more looking at the economic side. So how can value-based healthcare be ensuring to have a better cost containment within healthcare? And there are other initiatives from the European side that has been looked at how to define value, look at more broader societal considerations, and have other initiatives like the EIT Health is having a pioneering for value-based healthcare, for seeing how to bring in high-value care, as well as there is the European Alliance for Value in Health, in which the Hospital Association, European Hospital Association, is also part of it. So all of this in striving really to get this full system change. Now, in order to realize really the ambition and really to make it feasible already today, in order to do the implementation, that's where procurement and value-based procurement can really have a key role. By looking actually at the core, indeed, the same of, okay, how is by bringing in these technologies, this innovation to the purchasing procurement system, how can this help the outcomes? How can this help actually the cost and the optimization of the cost of care? But also, what's the value that can be brought for other benefits, for the other actors in the system, and even more broadly from a societal perspective. And so procurement actually is becoming the unexpected driver in value-based healthcare. And as indicated, it's inspired also by the paper on incorporating value in investment decision, which is more looking at ultimately what is valued and what are the values that the society are putting forward and is willing to invest in, and actually to bring those into the equation. And it's all brought together also in the publication of how procurement actually unlocks value-based healthcare. Now, what is value-based healthcare and value-based healthcare procurement bringing? It's actually, I would say, a triple win. So from a provider's procurer's perspective, it does improve patient care, it does address financial sustainability through also the involvement of multidisciplinary teams. So how is it actually bringing then this patient-centric care, which is enhanced by measuring the patient outcomes and involving the suppliers also in the care improvement? The financial sustainability by the fact that it actually improves the focus by focusing on the improved efficiency across the pathways. And also, in order to support this, to actually go into value-based contracts with the suppliers. And then it's important that it is driven by multidisciplinary teams in order to get everybody on board, get really into a shared purpose in finding then the best solution for the patient care delivery. It's also a win for the MedTech suppliers, as the MedTech suppliers can become part of the solution, which actually is fostered by a stronger dialogue with the procurers and with the hospital environment in order to seek really what are the specific pain points and how can this actually be addressed in improving then the outcomes for the patient, be of benefit for the healthcare providers, but also ensure to have a good cost containment. It will reward the value of the contribution, and it also allows to actually contribute to innovating the care delivery, to really see how with all this new advances in technologies, in offerings that there are, how can we actually further advance and innovate the delivery of care. And then it's also a win for the healthcare systems, which can enhance care integration, improve population health, and increase the return of the resources that are invested. And this is something that might be needed to have an increased awareness in Belgium, to see really how through these channels and how to ensure that incentives are being put in place to actually reach these objectives, to have then the integration across the care delivery, to address the population health due to the improved outcome transparency, ensuring that there is a lower variation in care practices, as well as to go much more patient-centric and personalized, and really see how that the increasement in investment can actually support the best sustainable contribution to the patient health. So now looking into, okay, if we're convinced that this will be a win-win, is the environment ready? Is the legal environment, is the procurement environment ready? And the answer there is absolutely. I mean, this is really a fertile ground. The EU Public Procurement Directive, which has been put in place, is really supportive for innovation procurement, is supportive for a shift towards a value-based approach, which at the same moment, by going into a value-based approach, is also leading to economically the most advantageous solutions to be brought into the system. So it's really a win-win from seeing the value benefit side, but also that economically this makes the most sense. And there are multiple articles in this directive, but it's specifically looking in the awarding where it's becoming important. So how, if you have different offers, how to actually select one versus the other. And it's indicated there that it's important to look at what's economically the most advantageous, and to do that by looking at the best price-quality ratio. And then the question, of course, comes, okay, how are we getting into this best price-quality ratio, and what's actually the interest of the countries to actually move into this direction? And as you can see in the implementation of this directive in the different countries, the majority of the countries did actually include the primary focus of putting a quality component into the purchasing procurement dynamic. And how is this now translating into the concept of a value-based concept? This is by actually where you primarily start with looking at a best quality price ratio under the environment of the quality. Under the quality dimension, we can bring in actually the added value of better health outcomes, improved care pathways, additional benefits for the patient, the carers, healthcare professionals, and even for the health systems and the society. It of course needs to be linked towards the subject matter, which is actually purchased, procured, but those elements can be brought in the consideration of awarding one offer versus the other offer. On the other hand, there is the element of the cost, the price cost side, where really an economic consideration can be done. What is actually economically the most advantageous, and how can actually the cost being lowered by looking at the potentially avoided costs into the system, by looking at more effective, efficient treatments along the full pathway of the patient. And so this results in what we have then put forward as the MEET value-based procurement framework, a framework in which the core is looking really at what is the outcomes for the patient, what is actually then the cost of reaching these outcomes, but at the same moment to consider what are the further benefits that are there for the patients, for the healthcare professionals, for the health systems, for the providers. And even beyond this healthcare setting, you can actually bring in looking at more policy-oriented interests. So what is actually potentially of interest with regards to the sustainability, the environmental benefits, the aspects of bringing innovation, broader socioeconomic benefits. Those can be brought in if ultimately people are valuing these, and if there is a degree of willingness to pay for those. So going into a little bit more detail with regards to this first dimension of the outcomes, because it's one of the core elements. The question is, of course, is outcome being taken into consideration when procurement is being done? When we actually started this exercise, it was very awakening that actually none of the procurements indicated that they took into consideration the outcome for the patient. So this was not part of any of the criteria that was looked at. So the purchasing was not done in the context of what ultimately is the outcome that it brings for the patient. And then the question is, of course, okay, is these outcomes, is it just a clinical outcome that's being considered, or is it really what outcomes that matter to patients, and which are those that can be taken into consideration, and what's the type of evidence that you have at the time that you have to make the decision? So this is one direction to take it as an awarding, but the other one, and much more appealing, is actually that there is an outcome focus given. So really that in cooperation, it's aimed to really see how we can actually, by this innovation, by this technology which is brought in, to actually reach certain outcomes that are being obtained for the patient or for the system. And what is actually the support that can be providing in measuring those types of outcomes, and what's the degree of willingness not to have to pay upfront for those outcomes, but actually go into agreements and to create incentives when those actually are obtained at the end. So a lot of opportunities in this field to bring this component in with regards to the outcomes and the outcomes focus, and this both for well-established companies, but also for innovative SMEs to be part of the process. The other consideration is with regards to the costs. So what is it that when we look at the cost, and there people can take really stepwise approach. We can start really at looking at the cost and economic consequences by looking at the price, which is certainly one of the elements. But you can also look at more broadly and saying, okay, what is the price of the equipment, plus what is the cost of using this equipment into practice with regards to the maintenance, the storage. So what's the total cost? So what's potentially the total cost of operation? Or you can go even one step further and looking, okay, what's actually the total cost by using this in my care pathway? Is it actually avoiding some complications? Is it actually bringing some reductions in my cost of care delivery? And is that being taken into consideration in order to then see what is the true effect that it has by actually bringing these types of technologies, innovations on and or other solutions and services into the system. And this is an overview of what could be taken into consideration. Criteria are being identified which are most often used, so it's just a compilation of those, not aimed to be used all, but just to have as a guide for consideration. Taking it at the next level of other benefits for the key stakeholders, there is then actually, for example, looking at secondary benefits for the patients, but also what are benefits for the healthcare practitioners. It might be that you have a safety, a security element when you have look at gloves. That is important for the nurses, or having allergic reactions that you can be avoided. So those types of benefits can be actually taken into consideration. Same for the provider benefits. What is actually potentially the strategic fit that it has in the support of the strategy, or other benefits with regards to the maintenance, the organization that it actually brings within the system. So those can be taken into consideration, and then the broader impact on the society that can be taken into consideration. It's all dependent on what ultimately is valued and how does it actually link towards the subject matter. So this actually then translates actually the meat procurement into healthcare, where we can have then the overview of which are the different layers that are taken forward, which are the different categories, and then which are the different criteria, in order now to make a decision of what of the offers to choose. It's a quite simple metric to use then. The costs can be, of course, easily translated economically of what's actually the monetary amount to that one. but also the other benefits can be translated in what would people willing to pay for it, and in that way actually bring a monetary value assigned to it. And then the equation is that you actually calculate all the costs, you subtract all the benefits, and the one which actually has the lowest is actually having the most economically advantageous offer that can be provided. Now, not having to go always over this, what is the monetary value to give to some of the benefits, you can also put weights, and that's actually the classical way of doing it, to actually weight the different criteria to see a degree of importance that is given to them. So in this way, actually, we have now that the procurement, value-based procurement, value-based healthcare procurement, is really a key enabler into actually moving into a value-based healthcare system environment, and is something which already today can be implemented into practice. And if we then look at what are some of the consequences, and I leverage this slide from Hans, who has been building this up. So if you like to see what is the consequence of for the procurers, well, the procurers actually are moving from looking at the availability of goods, trying to do price reduction, looking at potentially a step higher the total cost reduction, into really seeing, okay, what's now strategically, how can I align the multi-stakeholder interests? So how I can combine the different interests that there are from the senior management, from the clinicians, from ultimately the budget targets that I'm having. So how can I bring this all together, even up to moving even further into contributing to the competitive advantages and the organizational goals, and in that way play a much more strategic role and have procurement playing a much more strategic role. And this to be, of course, looked at for which areas this can be applied. It can be done in the different quadrants of thinking, and of course it applies most best actually in the field where there is I would say a low supply risk, but a very high value impact that's being expected. It's certainly also applicable in the strategic area, but that requires then a more advanced investment team which needs to be put in place. But it can also apply very simple into the at the lower end for routine products, and take just one or two criteria to take it into consideration to get started with this rethinking of how to actually bring a value-based procurement into practice. Again, the specific procedures are available, so the environment is ready for that. It's then the skill set which is needed and the willingness, of course, from the different partners and the appropriate training and supportive tools in order to advance this. Now, what are the consequences from the supplier side? And a lot of the suppliers are certainly not yet ready in order to go there either. So it's also a dynamic which needs to come from the supplier side. It's actually to move away from the offering of a technology with the features and benefits, and looking at the volume price negotiation, towards really doing an offering which is indicating what is actually the value that this technology is bringing, what's the value of the diagnostic information that I'm bringing in the care system. Potentially going one step further into looking at what are the overall value propositions with regards to the solution and the services that can be offered, and to focus then on the rewarding of the value for those hospital solutions, even to a point of more even structural changes in the full organization in the healthcare system with regards to the offering of integrated pathways, cross-silo dynamics with then the appropriate financing mechanisms which are associated with it as well. So certainly also there a stepwise approach with different types of offerings that can be done, which could actually fit into the specific needs to address the specific needs. So it's something that we have, of course, a provider, the supplier side, but as important to bring actually in the whole multidisciplinary team to look at, okay, what are ultimately the criteria to take into consideration? What are the measures to take into consideration? What is ultimately valued? For what is it that we want to pay? Not to have just an academic exercise of a nice long list of criteria, but really see what will make a difference, and actually to bring those forward and have those very well identified and then measured into the tender. Which then also indicates that while we originally started that this was actually to support the awarding and have it as awarding criteria, we noticed that even more interest was actually to bring it actually much upfront. So really to say, okay, how can this framework and this tool actually support the dialogue in the pre-tender phase? So how can this help into identifying the needs, preparing the tenders, shaping the environment for the dialogue? Then also, of course, have it able to be applied in the phase of the awarding and the evaluation of the tenders, but then later on also to actually see how it can actually move into the contractual agreements, the contractual relationships to be applied. So it really is helping to rethink this whole environment of procurement into a value-based procurement, and really see this as an enabling tool to actually speak the same language, or at least to have the same starting point to discuss on the same basis. And so in summary, what we're actually then looking at into this value-based procurement is a first question to answer is, what is it ultimately that we're going to buy? Is it just a technology? Is it just a product? Or is it actually something which will help in our management of the care? Is it a certain solution? So what is it ultimately that we need? Where is actually the issue that we have, and what is it actually that we want to buy? It's a critical dialogue to have, and then also to find out what actually can the industry offer. What's available? What is the market offering at that moment? Is it something which is readily available? Is it something that with some modifications we can negotiate that this is being offered, or is it something that we need to co-create? So those discussions can take place by having a good understanding of what the market is offering, and that's also feasible to be done by well-structured market consultations to take place, and use the same type of basis in order to have these discussions. Once that's known, then of course the tender can be written, and then the question comes up of what matters the most to us. What's it ultimately to take in those awarding criteria? For what is there ultimately a willingness to pay, to invest in, and to bring those in, and linked to that one, actually, as indicated, have then this degree of, okay, what is the degree of willingness to pay for one or the other? Now it might sound quite complex, but it's practically done more and more often by actually bringing the team together and have the discussion with the multidisciplinary teams of identifying, okay, what would be now your interest to have this, and how important is this over something else. So bringing this then in summary again, as indicated, this value-based procurement brings value-based healthcare focus into the tenders. So if we're all convinced that we're going to do this, the question is then, okay, when should we do this? And I think there it's quite clear that the time to act is now. I think it's really with this perfect storm or how it further evolves, it's really a good point in time. It's quite clear that the status quo is not sustainable, that it is a win-win for all stakeholders, or it can be a win-win for all stakeholders, and that value-based procurement, and I think it's nicely that you put it as value-based healthcare procurement, is actually ready to move at scale. The environment is there, so the tools, the early experiences are in place. There is the value-based procurement community of practice, which Hans is leading. There are multiple tools in this community described. The case examples are now present as well. So really cases which have been awarded and which can be inspirational in this. There is the element of the starting of the adaptation into practice. Knowledge partners are being built up. We have the work which is done by RISA, who is the first organization who structurally has actually made the change towards really going into strategically taking this forward, that value-based healthcare is the norm to take forward in all of their further initiatives. And then, of course, there is the medtech industry, where it certainly will be a great partner, and certainly through the means of value-based and partnership agreements that this can take place. Having this environment in place, I think that in conclusion, I think it's really the right moment to go and to start and to partner among the stakeholders to realize this full potential of value-based procurement. I think we have the ability to work even within this current stringent setting. I think there will be opportunities in order for the provider and procurers to actually drive value-based procurement with comprehensive value perspectives related to outcomes and the cost of care across the pathway. For the medtech suppliers to develop evidence-based value propositions to address provider needs and enable their own teams to move into a value-based selling. And for the healthcare systems to foster this collaboration across the stakeholders, incentivize value, and enable further the healthcare digitalization. So by this, I would like to thank you and then look forward really to the next stage, which is really to make it concrete with a couple of cases from the industry side, international cases, as well as then further panel discussions where I think that people will see how to overcome the doubts that you still have in your mind in really getting started. So thank you for that.
Good afternoon. I appreciate the chance to come and speak with you today. Just a little history, personal history. I'm a nurse and have worked in the NHS for the last 40 years, prior to actually leaving 3 years ago to work with BD in the nurse manager role that I now have. In that time in the NHS, worked in several environments, but actually spent the last 15 years working in the NHS procurement landscape, specifically as a clinician and trying to drive a modernisation and a value agenda to integrate clinical thinking, clinical activity and clinical engagement into procurement processes. So even though I'm now working in industry, this is a topic close to my heart, in truth. I'm going to share with you an example which doesn't absolutely fit the criteria that's just been laid out to you. It is an early example of what we're trying to do in the NHS. And we have lessons to learn, and certainly the ideas that have been presented just now are part of our learning journey. So what we've tried to do is move towards a collaborative approach, which I'm now struggling, forgive me, to advance my slide deck. Thank you. So I'll take you through a pilot study that we ran, and this was looking not at a large-scale transaction. This was looking at the use of consumables in and around the hospital environment. So this particular organisation, the trust is University Hospitals of North Midlands. They catheterised, so this is a urinary catheter intervention, something that happens to a lot of patients. They were catheterising between 1 in 4 and 1 in 5 patients that came through their hospital doors and were inpatients. So across the two campuses, that amounted to many episodes of catheterization each year. Well, part of the identification process for the trust was recognizing that actually they were performing below national standards with regard to procedurally keeping that procedure correct, but also on the patient outcome side. And I'll detail some of that in due course. The other partners in this were BD, ourselves, as one of the suppliers that participated in the process. The other and the third collaborator is an organisation called NHS Supply Chain. Now, NHS Supply Chain is our national procurement provider in England. It's mandated by NHS England to all trusts that they should use the NHS Supply Chain contracts that are centrally set. It also operates all the logistics, the billing, the financial controls, and various other measures, and runs the procurement. The procurements that are run tend to award what are structurally frameworks, and those frameworks cover multiple vendors and multiple types of products. Again, I'll try and sort of give a little bit more context to that in due course. What I'd like to do, if I could do the next slide, please. Sorry. Thank you. So the challenges then that the trust identified were these patient harms that I've alluded to previously. So they had a higher level of hospital-acquired catheter-associated urinary tract infections. These are commonly called CORTI. They also had, and their rate of infection actually compared to the national average, which was roughly 1.3% of patients nationally in acute hospital sectors of this type. And their particular infection rate was tracking around about 2.1 to 2.3%. So actually significant patient harm that could be avoided. They also noted, and it was an unusual situation in this organisation, but they also noted that the catheters and the catheter care that their patients were receiving seemed to be causing a degree of genital trauma to patients. So forgive me, I'm sure you've just had a hearty lunch, so I've avoided pictures, but the skin damage that can be caused by long-term catheter use, if they're incorrectly applied, can actually be irreversible and life-changing. So the trust organised surveillance over the course of 3 months prior to engaging with us, and had some good, strong evidence of harms of this nature that were ongoing with both men and women. They also engaged with their staff base to just look at what was happening on a day-to-day basis, either during the process of catheterization, so that's inserting the catheter into the bladder, and also looking at the process. We supported them with what's called a zero-in audit, where we looked at the process of the care that's given to a patient once they have a catheter in situ on the wards in clinics. And in both situations, we found, if you like, gaps in practice compared to the standards that they were suggesting that they were following. So that catheterization had gaps and were failing to comply with the ANTT process, which is a process for maintaining asepsis. And in the care and maintenance of a patient who had a catheter in place, there were significant gaps again, and significant variation in practice as well. They also had an interest in trying to reduce the burden on the environment from the procedures. Catheterization is viewed as a high waste and a high plastic waste in particular intervention. So those are the parameters that they were looking to address through the procurement exercise, if they could. Next slide, please. you. So the procurement process, this is where it's a little different to what was outlined to you. We were working within the confines of a mandated system, and we were working in the confines of a framework system that is pre-awarded, but within which any trust can choose any of the given suppliers that exist on that framework to supply their goods. So the trust and NHS supply chain came out to the suppliers, the vendors, ourselves on the framework, and started a dialogue, started a conversation with us to say we would like a solution that will support us in improving across the 3 areas that were detailed previously. And that conversation, as I say, started probably took place over the course of 3 to 4 months, quite a lot of engagement, quite a lot of evidence that was passed through from various companies to them, which they had to look at, review, digest, and then formulate a procedural process onward from there. And ultimately, they brought through 3 companies that offered solutions to support better outcomes. And then they proposed that they would run a clinical pilot to actually, A, prove concept that by changing they could improve outcomes, and B, to determine which of the 3 options gave them the most improvement across the outcomes that they were looking for. So that was a procedure that they went through, not quite the detail that's just been outlined to you, but as I say, this was an early outlier and very consumable based. The next slide, please. Thank you. So the implementation process was successful, and BD's product and solution was the most successful in reducing and supporting the outcomes that were required. I mean, just to highlight, the infection rate was reduced by 100%. So they went from in the pilot site having no infections in the pre-pilot stage to having 0, from having I think it was 7 infections in the pre-pilot phase to having 0 infections in the pilot phase. They also saved time in the procedure, which a lot of the nurses took to be an added bonus. The financial impact did see lower consumable costs associated with the treatment of the illness, the CORTI. And from a sustainability perspective, they saw marked improvements on the clinical waste side, and actually an increase in the amount of recyclable carbon paper that they could put through their recycling system. And overall plastic waste was reduced as well. So there were some lessons learned in there. And in particular, the lessons for all concerned were to be very, very broad in the engagement across the hospital organisation, needing to include clinical staff, finance staff, procurement staff, and the trust operational teams, the people who are moving the goods and services around, and the people with responsibility for patient flow through the hospital as well. So that was very important to us. And what we learned very quickly was the benefit of having senior staff working as a senior sponsor for the project, just to iron out any creases that occurred on the journey. And we also obviously saw the importance of setting our baseline, and I described some of that baseline earlier. Thank you. Next slide, please. So the ongoing management process now that we've implemented, so we were successful in being awarded the business, and we've fully implemented now from the pilot side across the whole organisation. And we've set up a monitoring process at the moment with quarterly business reviews. Those, again, involve all the stakeholders. We think that's key and important. So procurement are involved, clinical and performance and finance are involved in those reviews. We've established a training partnership to try and maintain the good practice that the trust has identified through a repeat audit that they've seen the improvements they wanted. And there's a training partnership to try and support that on an ongoing basis. And in particular, what's pleasing for us as a company, and I think for the clinicians involved as well, is that we're starting to have conversations about gaps in the whole pathway and seeing if there are innovations that can flow from that gap identification, where there are unmet needs. And that gives us a nice platform to move forward from in partnership, really, which is the key to the whole process. So it feels as though it's been a success all round. What we know is that we want to continue the journey and actually adopt much of the sort of well-informed practices that were detailed prior to my presentation. So thank you. I think the final slide, thank you. Thank you very much.
Thank you so much. Let me first say that I'm actually extremely excited to be here today. This is my first conference. I'm not sure how it is for you, but I'm really happy that we can do that again. Next month I will be the first time flying again to Germany, my home country, for another conference in Munich. So really happy that we are starting off this. And thank you so much for the invitation. I'm really glad that we can talk here today a little bit about what is really possible in the hospital environment. And when Yves asked me to present here today, I was really thinking, okay, what is a good example that we could also realize in the Belgium environment and in European markets? I have an example of a hospital in the US today, but before that, if we go to the next slide, please, let me reinforce the message again around value-based care. And Yves already mentioned, we're at the moment at a tipping point where healthcare is getting unsustainably and it's extremely expensive where we are moving to. And we have finite budgets, so meaning that even if we have new innovations coming in, new treatments coming in, it won't be more money available to pay for this treatment. So what we need to understand, what kind of additional value do these treatments bring, and how can we actually decrease cost somewhere else, because the budget won't increase any further. And to do that, going to the next slide, please, Yves also already mentioned nicely that we need to start partnering closer. So it is not only about a vendor like Philips or also the other colleagues from other companies looking to sell technology, because that's not what we should be doing. We should be looking on partnering up together with hospitals, with institutions, to look at how can we improve at the end the care of the patient, because that's what is most important, and that's the interest of the hospital, and that's the interest of us as a health technology company at Philips. So it's about thinking on how can we share risk, how can we use data that we have now due to new technology systems, and understand how technology and also interventions are performing from an outcome perspective, and then look into continuous improvement and see how we can, over a long term, reach together our goals with this, at the end, healthy population. Going to the next slide, please. My example is an example from the US, which is a hospital. It's called Houston Valley Medical Center. It's a hospital in Tennessee, where we together looked at a commercial contract that we had already with the hospital. It was around devices and devices that are in the area of ultrasound, intravascular ultrasound, so navigation devices. And we had an existing contract with the company. But we saw that at the end, looking at the national average on how the devices are being used in other hospitals, this customer was not really taking up as much the technology. And then looking into, okay, what are the main hurdles for this? We identified that the biggest hurdle is that there was a missing understanding on the value and the cost reduction that you could achieve by using IVUS and IFR together in a navigational approach. So what we did, we said, okay, let us create a shared risk contract where we will create KPIs for, in this case, and if we are meeting the KPIs and reducing really cost in the hospital, so here again, coming back to value-based care, adding value to the patients and to the healthcare system, while reducing cost for the hospital is what we wanted to achieve. And things that we're running into, first of all, it becomes very difficult to benchmark or selecting at the end the right metrics. Also, just to make the hospital aware of what kind of data they're actually sitting and having access to the data. I worked for many years in hospitals myself in Germany, also in hospital management, and know that it is so difficult in the EMR. You're getting completely lost. There's so much information there, and it's just really having the right dashboards in place. And then committing on it on the long haul. You won't achieve everything in 1 year, but you really need to think, what can we do to make this happen over a long course? So looking a little bit into the outcomes, and that's what I wanted here to present today. We also published this in the advisory board, so this is something accessible. If you want to ask me, if you can move to the next slide, please. Later, I think I have also the trigger here. I've just found it now. I will use it from now. So here, seeing really the outcome of the work that we have done. The baseline assessment, the contract that was established with the hospital, was around 180,000. What we put in as a risk portion, $50,000 or $60,000 on top of it. And then we looked at different metrics, at readmission. We looked at acute kidney injury, which is the second one. Then we looked at patients that were sent home at the same day. And then we looked at also at variable cost. Why we could improve all of the metrics, only on 2, we really achieved what we also promised to the hospital. So that's why we at the end divided the shared risk by 2 and had an additional device cost for the hospital of $30,000. If we can go to the next slide, please. Here we go. So what you see here is that the incremental device cost for the hospital was $30,000. Nevertheless, on the left-hand side, you see that there was a reduction in supply cost, that there was a reduction because of the acute kidney injury, the incidents that were happening, and that there were also the reduction in patients staying longer in the hospital. So at the end, we had a cost saving for the hospital of $100,000. Where they initially only had to understand why that is. So what we could do with this, over the last years, this was published in 2018, we could take up more and more IFR and IVUS devices within the hospital, which reached them there now even bigger numbers, and I can now already, it is not published, but I can say that we achieved our promises actually at the end also on the all 4 metrics that we wanted to approve. Nevertheless, in this case, it was the first 2 because it was after 1 year of duration of the contract. What does it mean for us looking at it also from a European environment? Real-world evidence, so meaning understanding about the data that you have in your hospitals is crucial to improve clinical and economic outcomes. Then outcome-based models are definitely a promising way on how to work together with vendors. That it's not this traditional transactional, I sell you a device or equipment or a software and I get in return directly money. It's about sharing the value that is being provided. And then, creative strategies by stakeholders. They need to be provided to achieve better quality at lower cost. Coming back to the value-based care definition. That's what we want to achieve. And then finally, we are aiming at the end to introduce those models at the moment in the European market with integrated care solutions. Every healthcare system is different, and specifically in Belgium, even in Belgium, there are many different opinions and many different regulations. So we need to adapt to this, but by partnering up, this is one option on how to do that. That is my presentation for today, and thank you so much for your attention.
My name is Martin Ackman. I'm head of the value-based healthcare strategy for Medtronic in Northwest Europe. I've been with Medtronic for 5 years. I also sit at the board of our diabetes type 1 clinics, which we have 5 of those clinics in the Netherlands, also in Saudi Arabia and Spain. We're expanding. So I'm going to talk a little bit about that more, also in the light of value-based procurement and value-based healthcare. Before joining Medtronic, I was head of the procurement department for the largest insurance company in the Netherlands, where we had 6 million policyholders and spend an annual amount of around 14 billion euros a year. So I have a little bit of a differentiated background, but also a procurement background. Today, I'm going to talk about value-based procurement, but also from a medtech perspective. And because we partnered with a clinic, so the clinics are part of Medtronic, I'm going to talk about a little bit more broader, the integrated chain of care delivery. So a medtech company, a clinic, and an insurance company, and how we deal with that. And if you look at Medtronic and our vision or our statement about value and value capturing and value-based healthcare, all those different definitions, as also the previous speaker said, technology alone is not going to improve outcomes. You need expertise, you need data, but most of all, you need partners in the field that want to join up with you. There needs to be a trust. And then when you join together around the patient, around improving outcomes, then you can create value. And I think that is something that is said often, but done little in healthcare at the moment. And hopefully we can expand that kind of tradition also across the globe. Today I'm going to talk about diabetes type 1, so not type 2. Type 1 in the Netherlands, specifically, we have around 100,000 patients in the Netherlands that have type 1 diabetes. So this is not something that comes from dietary or from older diseases, but this really comes from inside the body. So most of these patients are diagnosed with their type 1 diabetes before the age of 25. So 75% of those patients are already diagnosed on a very early stage. Compared to the type 2 population in the Netherlands, it's around 10%. So we have around 1 million type 2 patients in the Netherlands. If you look at, why is it important to focus at, improving outcomes and creating value for type 1 patients? These patients live on an average 12 years shorter than patients that do not have type 1 diabetes. Looking at school results, children perform worse because they're occupied around 3 or 4 hours a day with their disease. Productivity is lower because of leave of absence, because of sickness, because of distractions because of the disease. Welfare costs are higher, but there is also a huge amount of complication costs, which I'll touch later on. And in the Netherlands, but also globally, 60 to 70% of the patients do not reach the targets of blood glucose that they should have. So this has a consequence for the health on the short term, but also on the long term. And the care around type 1 diabetes is not organized in the right way. And when you look at the equation that we already saw presented, better value, the Porter definition, better outcomes divided by lower costs. If you look at for diabetes in the Netherlands, only a small country, 70 million inhabitants, just a little bit bigger than Belgium, it's 500 million that goes to the insurance companies. We have 5 big insurance companies, so no mutualiteiten, so private insurance companies that are controlled by the government, but it's 500 million euros invoices directly to the insurance company. If you look at the indirect costs, so lower productivity, welfare costs, lower school performance, it's around estimated it's 1 billion a year. And if you look at the loss of life, the 12 years, you capitalize that, it's around 700. So for a very small population, around 70,000, 100,000 patients in the Netherlands, the total cost for the society is around 2 billion euros. 2 billion euros for such a small population. So there's a huge value that can be created, not only on the cost side, but also on the outcome side. And if you would improve outcomes for this population, which is very possible, increase quality of life, lower acute emissions because the control of glucose is better, less secondary complications, and you would lower the costs, which is also very possible. And these goes very hand in hand because lower admissions in hospitals also goes hand in hand with lower costs. And you do both 20%, you create 50% more value. And I think that's the ambition that Medtronic has in collaboration with the type 1 diabetes clinic, but also with other hospital payers. And it's important to know that blood glucose in itself is not an outcome because patients usually, when they're in between, they don't feel it. But if they go low, they end up in hospital. If they go high, they feel very worse. And the blood glucose in the body is in very high correlation with important outcomes that do matter: survival, complication, admissions. So it's a kind of a surrogate outcome, which is very important to keep in certain boundaries. This is a picture of one of the clinics that Medtronic acquired in the Netherlands. So they all look the same, but they don't look like your typical hospital. There's people don't wear white coats. It's a very child-friendly hospital or clinic, as you want, because most of the patients that come there are the younger age. We also treat adults. We treat everybody between 0 and 100 years. But it's not a typical clinic. And when you look at the tables in the meeting room, they're round because the dietitian or the doctor or the nurse sits around the patients with the patient around the table, and usually also accompanied by their parents. This picture was shown somewhere in the first presentation, and this is Porter's value strategy that he has been written about in his book, which is so famously. And if you look at all the 6 elements of this value agenda, I'm going to touch base on them, describing the clinic that we have. First of all, the clinic that Diabetes represents is organized in an IPU, an integrated practice unit. And of course, this is a typical male metaphor, but it's organized around the patient. So when the patient comes in, you can see the patient as a Formula 1 driver, Formula 1 car, and the team around the Formula 1 car, when there's a pit stop, everybody has his task and everybody knows exactly what to do and in a very short time. So the patient comes in, sees everybody, doesn't have to come back, everybody's informed, everybody has an up-to-date dossier, and then the patients leave seeing everybody. So no repeated visits and the whole patient as seen as a whole. So this is a very patient-centric approach that we have implemented in these clinics. Also, this is a complicated slide. I'll talk you through it. The only important thing is that we measure everything from the patient on a daily basis. We collect 250 parameters every day, data that is being generated by insulin pumps, insulin sensors, and other data that the patient fills in. So we monitor the patient on a daily basis. And when something goes wrong, very blue or very red, we keep in touch and we bring the patient in. And also when you look at the outcomes, average hospitalizations due to this illness in the Netherlands is around 10%. Diabetes at the moment cruises at 1%. So 10 times less hospitalizations due to the very intense monitoring of its patients. And also when you look at the outcomes that we compare with other care providers, data from the US, here you see the big ball is diabetes. And this is, the score compared, how well are people in range and how are the blood glucose levels. We do, probably top 3, top 4 in the Netherlands, which is quite an achievement, but we're also very transparent about this. Another thing that has been talked about is that we also measure costs. Of course, we measure the cost that we invoice to the insurance companies. We also must measure the cost of care delivery. On average, we see, per nurse, per doctor, we see twice the amount of patients, which in a cost perspective is very efficient, but also the amount of, experience that the care providers get is much higher than in the average hospitals in the Netherlands. At the moment, we have around 3,000 patients in our clinic, 3,000 patients out of 100. You can say, well, that's not a lot, but still, together with Steno in Denmark, we're probably the biggest and largest diabetes specialized clinic in the world. Then about procurement. Diabeta has, 2 years ago, we sat down with the largest insurance company in the Netherlands, and actually we wanted to move away from the transactional negotiation on price. We said, can we have a contract where we really focus on value creation for the patient? So not only looking at the short term, but also on the long term, how can we prevent short-term complications like hospitalizations, but also long-term complications like blindness, renal care, amputations, wound care, cardiovascular incidents. And they were very open to that. And it was not a 1 week discussion. We took, almost 1.5 years to draft this agreement. But eventually we drafted a 10-year value-based healthcare agreement. And actually we created the first bundle payment for type 1 diabetes in the Netherlands, but also in the world. And what does a bundle payment mean? Porter talks also about move to bundle payments, he says in his value agenda, which means is that you are completely responsible for all the care that the patient receives in the clinic, but also outside the clinic. You can only do that when you have all the data from hospitals and care that has been provided outside your clinic, which means insulin retrieved from pharmacies, hospitalizations, other care that has been given to your patients. And that's where you need to partner up with the insurance company because they have all the data. So we receive a fixed amount for our patients. And if we do better, there is a saving. And I think that is the principle of how we actually created the kind of procurement. Out of procurement, we created the value-based healthcare concept. In this very simple graph, you can see, here you have on the left side all the individual activities associated with the care for type 1 diabetes patients. Then we moved and calculated, what is the amount of money that we actually need for the patient. And in the future, we have, quarterly meetings with the insurance company, and we calculate all the costs, including the outcomes. And that, reduces the costs, which we already see, and that generates savings. And that's money that we can reinvest in our clinic. And that is also a savior for the insurance company. But most important, we see, value created for the patients. And this is a very simple, scheme. G20 was also mentioned. We were lucky to, before COVID, to present this bundled payment on the G20 in Saudi Arabia. You can see here some of the slides that I also am presenting now. So we were very fortunate, but also very honored that we were on stage with, several stakeholders in the world and presenting on this first, value-based healthcare bundle payment, which actually came from a procurement because it's together with the insurance company. If you look at, the whole value chain of the clinic diabetes, you go around the clock. Actually, we do everything that Porter has described in his value agenda, including a dedicated IT system, looking at monitoring costs per patient, but also looking at outcomes for patients, move to bundled payments. We have expanded to other countries like Spain and Saudi Arabia and opened clinics there. And then most important, we measure the outcomes and improve on a continuous basis. Most recently, we have also been awarded by the World Economic Forum as a best practice in value-based healthcare. And the procurement part, the bundled payment was a big part of that achievement. Maybe as a last, because, what are the learnings? Very from a practical point of view, how did we as a medtech company / type 1 diabetes clinic engage with the procurement organization in the Netherlands? I think the most fundamental thing is that you need to first set targets on what do you want to achieve on outcomes, but also on cost, not only on the transactional short term, but also on the long term, 5, 10, maybe 15-year window, which is unheard of in healthcare, but you really need to do that. You need to think about incentives of value improvement, not only money and cost cutting, but, what is it that we want to achieve and how are we going to incentivize that? Typically for the clinics, Most healthcare providers in the Netherlands are capitated and budget. We don't have budgets. So the insurance company wants us to grow as fast and as possible because they see that our healthcare is good. They see the transparency, so there's no boundaries in growth. Take integral responsibility on what you do. This could be, a small thing for cardiovascular diseases, but this is now in place for diabetes. Commit for the long term. It's long term is crucial. And I think be transparent, create that environment where you can share data, even if it's not good, do it, because otherwise, there's lack of trust. And I think the most important thing in this is gain trust with your partner. As a medtech company, it could be a hospital, medtech company combined with hospital, you could engage with governments or with insurance companies. So you also could team up, which is something that we do in Medtronic as well. Trust is super important. There's known knowns, and then you get a contract because you can put everything on paper. Then there are no unknowns, which means that you have already a more complicated contract. And then in the value-based healthcare, value-based procurement sphere, there are a lot of unknown unknowns. And that's really the phase where you need to trust each other and sit down. If somebody has a bad year or has disappointing records, don't punish them for that, but be transparent and also reward that. And that needs to come from two parties. I think this is my last slide. Very simple schematic picture. Everybody knows a cappuccino or a coffee. And what you see here is, starting out with value-based procurement, you don't have to start out with a model like diabetes where you have the full-fledged value-based healthcare and tick all the boxes. But you can also say, with a hospital or a procurement organization, let 90 or 80%, let's continue how we did it. But let's start with, maybe a small layer of outcomes that we can add to that, to that tender or to that, in this case, cappuccino, where we, commit to outcomes or commit to certain KPIs. And then you are in a nice spot because then you're already moving away from the transactional, I think value-destructing contracts that we now have in medtech, in the pharma industry, in healthcare in general. So I think with that, it's my last slide. I want to thank you for your attention and look forward to further questions. Thank you very much.
I will now invite the panelists.
Hello, everyone. So my first question will go to Eric. Eric, as a hospital manager in Belgium, are you considering value-based procurement in your hospital?
Yes, I think we need a microphone.
Wait, I should do this. Okay.
I think I can say we actually already apply value-based procurement in our hospital. Certainly not to the extent of the sophisticated model we saw from Medtronic, but we definitely consider other criteria than only price when we make purchases. Two examples, a very simple one. When we buy syringes, we do not only look at the price, but we also consider the packaging they come in, because if they come in big packages and we have to unpack them before we bring them to the wards, obviously we will have an inside cost that is not reflected in the buying price, but we will definitely have to pay. And on the other hand, we recently opened a new center in Bilzen near our main campus. And when we talked to the architects, we took very much time to consider the walking path of our people working in the hospital, because it had a very high impact on the cost of operating the center. Not only the fee to the architect and the fee to the builder was important, but also the cost we would have operating the center. If you need 2 nurses more because your walking paths and your walking lines are not very intelligent, it's a major cost of 150,000 euro a year extra. So yes, we do, but we can do definitely more than what we do now.
As I hear you're reducing costs, but what about outcome? I mean, are you taking outcome in the equation in your value-based procurement model?
not enough. That is exactly why I said that we need to do more. I think in the future we will focus more and more on proms and prems, and that is the main challenge we will have, how to introduce the measurement of the proms and prems and the outcome, how to introduce them into the value of the purchasing of the procurement we needed. And that is where we look at our suppliers, at our partners, because they will have to help us when we buy a new product, for instance, or a new software. I always ask, what is the reporting I will get with it, so that I can learn from it. So if a supplier or the industry gives me what I ask, I will be satisfied. If they give more than what we ask, we will be happy. If they will make us smarter, we will love them.
Thank you, Eric. One more question, but we will discuss maybe the Belgian market. I mean, the specifications of what's happening in Belgium. What you heard just before were examples from outside Belgium, and this is somehow inspiring, of course, but also challenging, because why we don't have examples from Belgium? And we will get to that later on. So, Eric, do you think that this exercise you're doing into implementing value-based procurement, could it help in enhancing value-based financing models in Belgium as a part of bringing quality for patients? I mean, does this really improve the dialogue and the ideas inside your hospitals?
Well, one of the reasons why we looked into value-based procurement is that we are triggered by the financial situation of our hotels. Every hotel in Belgium is looking for money. We are all underfinanced, so we always need to reflect on ways to make more, to create more value with what we have. So definitely it can help us, but it will also have to be integrated in the new financing systems. Also because, as I said, proms and prems are more and more our focus, and they also will be a part of the financing. We will get the funding we will get in the future. So clearly, value-based procurement is not just a whiff or the candy of the month, but a strategic decision.
Okay, thank you. So I suppose we are all meat lovers, and now I'll give the floor to Paul. Paul, you'll go through others' questions, please.
My next question will be for Hans Bax. What structural challenge do you see, and what are the structural challenges you see for the future in this sector, and what are the examples for other countries you can? Yeah, do you see? What challenge do you see for Belgium now, and do you see example for other countries that could be interesting for us?
I think it's first most important to understand that value-based procurement is not about the procurement department or the pharmacy department buying medical devices. Value-based procurement is about the buying process and the buying function in healthcare provider organizations. And it will structurally change what you buy, how you buy, from whom you buy, and more important, why you buy. And this is easy said, but then we come into the difficult area. But there is this very interesting example from France, from the University Hospital of Lyon, and this was on hypothermia prevention of patients in the OR procedure entering the recovery room. And I want to share this example because here again the traditional behavior of procurement was to run a new tender because the old contract was expiring. But when then the supplier asked, what is your hypothermia rate? Procurement didn't know. The OR management had to find out. And they found out that over 55% of patients entering the recovery room were hypothermic, even though they were using these warming blankets. So running just another tender would result in another contract on blankets, maybe at a slightly lower price, but it wouldn't solve the problem. And I think this is the core of value-based procurement. It is not a procurement trick. It is a structural change of your procurement function and procurement profession in your hospital?
Thank you. Yes. So this is maybe a great topic, hypothermia. In order to move further with the questions for Virginie. So this is typically a tendering way in Belgium. So we want to buy equipment, and we don't really measure the outcome. Do you think that our public procurement law in Belgium is a real barrier to an obstacle to value-based procurement? And if yes, what would be the alternative to this?
Well, no, fortunately. And actually the Belgian law is not different as more or less all the other laws in Europe, because as most of you know, public procurement is 90% European directives. So it's quite similar in all countries. So we have all the same constraints, but also the same opportunities. So no, I don't think the Belgian law is an obstacle to implement value-based procurement. It all depends on how you will describe what you are purchasing, which procedure you will choose to enable that, and how you see the contractual partnership with your partner or the firm that will supply the products or deliver the services. And that all needs a lot of reflection, strategic reflection beforehand, to be able to implement that in the clauses of your procurement process, which is totally possible. But a lot of things have to be anticipated, because if you do not anticipate them, then you're stuck afterwards. For example, I saw in the last presentation that you have to think long term and make unknowns possible in the course of the implementation of the contract. Because it's true, you have alias, you have innovation, but in a procurement process, the law does not allow for change. So if you want to allow change, you have to anticipate that and modelize your change. Put measures around it, and then it's possible. So I think nearly everything is possible, but it has to be anticipated.
Thank you. So I hear that the law as it is not really an obstacle, but we have to do all the paperwork in order to imagine what would be the perfect contract, and that will answer all future requirements and outcomes that we are targeting, correct?
Yeah, well, it's not really paperwork. It's strategic thinking, and probably with all levels. Well, a lot of people in the hospital, not just the purchaser. You have to have a lot of people involved to be able to write something down that will work in the future, and therefore you need a collaboration between the people, all the people that are involved in the purchasing process and that will use what is purchased. So you need a reflection between the physician, the nurse, the purchaser, maybe the direction of the hospital if it's a strategic purchase. But no, the law is not really an obstacle. It's just you have to play with the rules that exist.
We already have a lot of litigation. When we will go to value-based procurement, with more, let's say, subjective measurement. It could be real objective outcomes, but also experienced outcomes. So would this lead to more litigation and more complicated relations between suppliers and hospitals and between suppliers between themselves?
No, I mean, I'm a lawyer, so I have litigations like more or less every week. And not more in complex contracts than in simple contracts. We have litigation in very simple contracts based only on price, but still you have litigation because prices can be abnormal, you have a lot of verifications to make. So And actually, if you talk about the litigation in the phase of the implementation of the contract, from my experience in value-based or outcome-based or performance-based contracts, you have rather less litigation, because in general you organize a long-term partnership with escalation processes, with governance processes, and you think more of all these elements, and in general the partnership is stronger. So I would say in the implementation phase you have rather less litigation. And for the award phase it's not more, not less than in every tender, and you're right, we have quite a lot of litigation.
So
for
it
the
will
moment.
be same. Paul has a question for you also.
I have the feeling that litigation is the first explanation why all those people now put the price as number one to decide, because they fear of litigation, because it's more objective, the price. When you want to be more secure in the process, you fix more the level of the price in the tender. I have this feeling. When you ask our staff for the tenders, they all the time say, okay, the price, something objective. The rest is more part of the appreciation.
Yeah, true, but you can have a lot of variations in price, and that leads also to litigation, because these variations should be explained, and then you have to have interrogation about abnormal prices, and that's a whole Pandora box that you open as well. So I'm not sure that tenders based only on price are less a source of litigation. In the construction sphere, we have a lot of litigation, and most of the tenders are based only on price, and we have a lot of litigation. Prices can be quite different, and that leads to litigation as well. And you have also a lot of litigation about the administrative part of a procurement process. Not so much about criteria in general, because that's the discretionary analysis of the hospital or the contracting authority. And if they do that in a transparent, professional manner, it's okay. They have this latitude to be a bit more subjective on some criteria if they do it on a professional way and their motivation is transparent enough.
Thank you. Maybe one question for Catherine?
Sure.
It's not working. Okay. Is the contract management not much more complex with this system?
For the industry partners, you mean?
Yeah.
Well, I can give the answer from a regional perspective and from a local perspective.
Yeah.
In Belgium, actually, we do not have many value-based agreements or value-based procurement. We are just simply very unfortunate and very challenged in the Belgian situation. Let's put the difficult topic on the table. The way that the hospital funding is done and the reimbursement system is not incentivizing quality. So it's the biggest challenge, I think, that we all in the room have when we're talking about value-based procurement. So from a Belgian perspective, at the moment, the contract management is quite simple, because it's still, if I took the position 3 months ago, I was very eager to start implementing value-based agreements and say, yes, we're going to reduce surgical site infections and we're going to guarantee a reduction, but nobody is asking us. So in theory, a value-based agreement requires quite some effort, especially from the industry partner, but also on the hospital side. You don't have to ignore that one. But it will have quite a lot of impact too if it's done well, and it doesn't have to be complex to be done well. But at the moment in Belgium, we still need to crack the nut, let's say.
And our outcome agreement not much more complex as performance need to be measured. The point of the industry compared to the jurist. Yeah.
And I think there, indeed, value-based healthcare is about improving outcomes. Improving outcomes, we all know you do by optimizing your process, standardizing your process, automating your process, tracking the data of process. And also there in Belgium, we're not again there yet, but we will get there, and it's improving. A lot of industry partners actually are offering tools to measure. And I think the key really is there, that if you see, and it has been said multiple times, the challenge is as big for the industry as for the hospital partners. We are in the same boat, so we need to think of the solutions together with you. And the challenge, if we see as a challenge that in a certain country there is not sufficient data available, we will have thought about this as well. But the question should come from the hospitals as well. Do you have a solution to help us measure? Did you think, or could we conceive together a way to improve those anastomotic leaks and reduce the surgical site infections? I think from an industry perspective at the moment in Belgium, the biggest issue is that the question is simply not asked. The question is, what is your price? And what is the feature of your product? Not how can you help me improve total cost of care, and how can you improve an outcome?
From your point of view, will it require changes in different expertise in the staff of the hospitals, from the legal or the nurses of the other part of the hospital?
Well, actually not. I think what we just all have to do is what was said before, collaborate better and build that trust together, so that we can actually sit around a room and talk about what the challenges are, both from the industry side and from the hospital side. The downside from a hospital perspective is it takes time, it requires resources. I do believe people have the knowledge and the capability of doing it, but we need to build that trust and that expertise together.
You spoke a lot about data, but we are few data systems in Belgium. How do you see the future perspective about data, and certainly in this business?
I think that partly also thanks to the pandemic, the change is upon us. If you see at the level of electronic medical records, the use of applications, but also the increased data use by the Ministry of Health, we are getting there. I'm not saying that it's for tomorrow, but data availability is increasing rapidly. It's just a matter of making sure that we can also use it and connect it so that it can show the correlations that we need.
Thank you, Catherine. So I feel like we are moving to the core of the problem, and I have one question for Yves, but before that, Eric, you said that the financing model in Belgium is not helping. I heard Catherine saying that we are lacking measurements and data, so hospitals could give that, but maybe they are not giving that because it's pointless, and they are focusing on the price. So we are focused on the price. So the question goes to Yves. Is the financing model in Belgium an obstacle? Is its redefinition maybe a prerequisite to move to value-based healthcare procurement? Could you give us some insight from your position? Yves, thank you.
I'm unfortunately not yet in a position to change the whole system. I would be otherwise happy to do so. However, I think it's the current system is certainly not an enabler. I think that's quite clear. On the other hand, I think it's important to see how other systems are also trying to deal with this. And I think there what you see happening is that that specific in the area of thinking about innovation procurement, there is also like dedicated financings which are allocated to it, which get then into more the case examples. And I think that's what's ultimately needed, that you have really first a built-up business case, and then have it implemented, and then have the showcasing it, and have to have mechanisms in order to support this, let's say, interim phase of financing. And there are multiple initiatives which are upcoming, both in Belgium, but also at the European level, which look at this type of innovation procurement. And I think it's worthwhile to look into which are those, to find a type of complementary financing streams in order to foster those change case examples, to then actually move in the next phase in the future transformation which will be needed. But I think it's I would not make it dependent that you have to first change the system before you can actually move into a value-based procurement, innovation procurement. I think it's the other way around, and that's what we try to indicate as well, that you have the ability to do innovation procurement, do value-based procurement, work together in partnership with the industry in order to bring forward case examples, and in that way somewhat push the change into the system. So I would not be too concerned in order to be willing to first change the whole system and the financing structures before doing the implementation. And within that regard, we also worked out a specific model which would be actually supportive of this, in which innovation procurement is a part, but also looking at, for example, the accelerated coverage pathways of innovation. Multiple countries have those put in place, and there's another element that we can bring forward of what is Belgium doing in those fields to really stimulate and support the uptake of innovation in the area of small case examples.
Thank you, Yves. So let me challenge you a little bit more. So you're saying we could move to value-based healthcare and procurement financing before we change the system in Belgium. But as you know, in some areas, for some products, hospitals are happy to spend in order to earn some money. So the more you spend, the more you earn. So why would they go to value-based procurement if they're happy to spend money, since it's not their money but the government money? Maybe you need some example, you know, like lab exams could be based on a value-based procurement. So you offer results, whatever machine you use and wherever you do it, and you really get outcome, and you have money savings that you could use somewhere else. But in Belgium, the more you spend to get lab results, the more you're paid by the government. This is one major example. So there is a lot of them. That's why maybe this is a part of the problem. What's your opinion? And then Catherine could answer also. Please, Yves. I really want to hear you on this.
Okay, so in total there is around 20 to 25 inefficiencies waste into the system. So of course, I mean, if you really want to continue to leverage that waste and increase that waste into the system, why not? But the system is going broke, that's for sure. So, I mean, short term, you might be interested to continue that dynamic, but this is not going to result long term into any opportunity to invest this amount into your innovation, into better outcomes, into your transformations which are needed, into the extra investments which are taken forward. And it's quite sure that with all the data capturing which is taking place at this moment, it will not take a long time before people figure this out as well. And in that way, we see multiple initiatives in multiple countries also that actually identify and in that way put actually the necessary measures to avoid this type of leveraging of the inefficiencies into the system. But now I
Sure. I can, because it's exactly that nut that we have to crack. To give an example, surgical site infections or anastomotic leaks, two complications where there is no incentive to solve them because hospitals will actually just be paid to treat the patient who is coming back with an infection or with an anastomotic leak. But that's the quick assumption that we're all making. There are plenty of hidden costs, but it takes time to figure them out. It took us actually 6 months to identify the saving that you do by avoiding anastomotic leaks in Belgium as a hospital. But it's work that can be done. The challenge is, does each CFO as a hospital have the time to really go through this? Probably not. Does it make sense for an industry partner to go through it? Yes. Is it easier if you sit together and you try to figure it out in partnership? Definitely, yes.
That was a part of my conclusion points. Thank you, Catherine. Paul, you want to add something?
I believe that it will continue as long as the government will see that the change is more problematic than pay. They will continue to pay. To a certain moment, they will say that they can't continue to pay, they have to change. And they surestimate the change and the fears. The last, la grève aussi, the stake of doctors, la grève de médecins, the last, is 60 years, is from 1961. 64, yeah, voilà. Probably the next one, they will change. But my feeling is that the government still overestimate the fear of change, and they prefer pay.
Please.
Yeah, On? Okay. So I'm Dutch, right? I'm from the Netherlands. So I try to be a little bit provocative now.
It's a different country. Yeah.
And then I run away fast back home.
You don't have to. You can go back there and live happily. We risk our lives in here.
Okay, good. It's about value-based healthcare. It's about value-based procurement. It's about value. And there is obviously a lack of sense of urgency. But we should put the things in the right order. When you don't have the data, you don't have a problem. If I don't have any data on surgical site infections, I don't have a problem. If I don't have any data on my readmission rate for hip surgery, I don't have a problem. I don't care. Second, maybe there's a lack of competition in the system. In the Netherlands, hospitals are on a limited scale competitors. So I can go to any hospital I want to go to. So what do when I need a new hip? I look at the outcome data of all the hospitals and I select the best hospital. Insurance companies don't reimburse cataract surgery with all 80 Dutch hospitals. They only reimburse with the 20 best performing hospitals. So there is this sense of urgency from the hospitals to perform better and to improve their outcome. And the really challenging part is maybe we need to look into criminal law, not procurement law, because we are withholding patients the best possible care they can get. And I'm not a lawyer, and I'm not sure if this is a criminal offense, but if I know as a clinician or a procurer or a hospital director that I can offer better care to my patient, but I'm not doing that because of legal, of reimbursement, of data system missing, I'm not sure. So we had Martin from an example from the United States. Maybe they're more well advanced on criminal law, but so. And in the end, it's all about the patient, you know. That is why I think we work in healthcare to have people living better lives. And so we really need this sense of urgency and just start on a very small scale, a small project, and then go forward step by step.
Thank you,
Okay,
Hans.
and now I'm off.
No, you're not that provocative, in fact. We are aware of this problem. We really don't know what we don't measure, and in fact we measure not that much, and we have not that much problems in Belgium, so we are really proud of our health system since we measure nothing, and that's why we're happy people. So there was this financing, let's say, difficulties, but I hear, Yves, to come back to you, that you're optimistic and you're quite positive in a way where numbers and data will go out and transparency will bring the change we all are waiting for. Is this correct?
Well, I think absolutely, because what's the alternative? The alternative is that we continue we're in a starting point with a decreasing in the quality. I mean, as a patient or as a person, I'm always perceiving the Belgium healthcare as a high quality. If that's correct or not is another question, but okay, that's the perception. I think that will go very quickly, that's going to decrease. The budgets will be not any longer there, so the question is where to start the squeezing on those, and you can squeeze on the small parts, which is on the innovation side. But I think that will not help it either. So I'm quite optimistic that we're into a very close perfect storm, and now after the COVID in a true situation that change will need to take place if we want to continue the quality offering, because we don't have any longer this luxury of moving on as before, in my opinion. I think Virginie had a point on it as well.
Thank you, Yves. I just wanted to add that in terms of data collection, we see more and more hospitals acquiring EMR systems, I mean performant and integrated EMR systems, and I'm personally convinced that will help the data collecting, especially if they are integrated really into the care
data is going out
system. So that's my view on something that is to be optimistic. And also it's true that in the medical sector we do not have a lot of outcome-based processes, but we have in other sectors, in the energy sector, sometimes in the construction sector, in the IT sector. So maybe because the procurement system of hospitals is a bit less mature than these other sectors where they have done procurement since many, many years, we can get inspired by other, for example, the energy performance contracts. They are really based on outcome, energy outcome, and this could be an inspiration for the medical sector.
Great, thank you. So this was the last question, and then I'll go to the conclusions. It's an open question. In order to bring this change towards value-based procurement and value-based healthcare, who should do the first step? Hospitals, physicians, government, politics, but also suppliers, companies. Who should do this, and who will answer this question? Yves. Yeah, you were chosen. It's like, I rolled the dice, and dice say it's you.
I think the industry has made a commitment. So I think it's not throughout the whole. I'm talking now medtech industry, because the pharma is not yet there. I mean, the medtech industry is clearly taking a lead in order to move from a product offering towards a solution offering, seeing how it can actually respond to the specific needs. So the preparedness is there already. I think in Belgium, I would look a little bit at the hospital senior leadership, because I think the opportunities are there. I think, as was mentioned, the knowledge is also available in order to do it. And I think it's to then take that next step and start to partner up and to have very well-defined cases, not to put a full change, but identify really a strategy and work together on that one and to partner up.
I tend to agree with Yves. I think as the one question that the industry probably has to the hospital management is take a safe bet. Ask us, or first internally, ask your surgeons, for example, which outcome, pick one, can you improve that will help me as a hospital as well, in my reputation, in my outreach. Pick one, and then go ask your industry partners who is willing to help improve that outcome. And perhaps we will even commit on it.
Thank you all. I'm happy you don't all agree. Otherwise, the panel would have been not really quite good chosen. Let's go to conclusions. I have like 5, 6 conclusions maybe. So what I learned today, first of all and most important, is that value-based healthcare is a work of a team. So everyone is equally involved. I usually speak about value-based from the physicians and the outcomes, the clinical outcome, without regard to the technical and the equipment and the material issues. And I learned today that, of course, it's more than of course, industry is really important because it's also providing the solution, the material, but also what can go with the patient at home. It's also hospital CEOs who could help inside. So it's really a teamwork in order to achieve it, to achieve this goal. Physicians, CEOs of hospitals, hospital leaders, and industry also, which leaves a part for the government, of course. And this is the second point. Competition is crucial. So financing based on outcomes should be more important. In Belgium, it's less of than 4% of the financing of hospitals, and regardless of what hospitals are taking from physicians. And so this is a part of the problem. So competition is important. Third point is time. On a timeline, time is now. It is now because there is no alternative, because there is no more money to pay for innovation. And we need innovation. Patients are requesting innovation. And in a digital world, patients request digital services. Then trust was a point that was mentioned by a lot of you. You cannot go into this adventure without trusting each other. And for now, maybe hospitals don't trust that much industry. Maybe physicians don't trust that much healthcare leaders. We need to work together, and trust is something really important. Thank you all for being with us, for sharing your knowledge and your experience. And thank you for the the attendance, of course, but the people who were online, and for you also, Martin.